Hello, good evening, everybody. A little change of scenery for me today. Not because I wanted to be in the backyard, because I'm not a big scenery person, but more or less because I had trouble with my Wi Fi inside and my ring light so that I could get more lighting so you guys could see me. But I did not want to not do my live, so I came in the backyard. But I wanted to just jump on real briefly today and talk a little bit about the thyroid stimulating hormone, the thyroid gland itself, and the adrenal gland. I think enough people don't really understand what's going on, especially in terms of the thyroid gland, what it does, how do we diagnose patients with hypo or hyperactive thyroidism, and how do we treat those patients. And then just very, very briefly about adrenal gland, especially when it comes to steroids and why we wean patients that are on steroids. So let's start off with both glands. They're both glands. There's multiple glands in the body, and that's both endocrine and exocrine glands. But for today's topic, the adrenal gland and the thyroid gland are both endocrine glands. That means that the hormone is secreted into the bloodstream. So that's called endocrine gland. Thus, when patients have very significant disease processes in terms of thyroid or adrenal glands, we consult endocrinologists because it's an endocrine problem. So the thyroid gland is responsible for many functions in the body: metabolism, growth, heart rate, whether or not you mince correctly, weight, you name it. The thyroid gland controls it. Very, very, very vital organ in the body, or gland in the body. So what does it mean? So when the thyroid gland secretes two hormones, T3 and T4, T4 is the predominant hormone that's secreted. So thus, that's why a lot of times you see TSHs and T4s ran in terms of blood work. The TSH is a stimulating product based upon what is going on with your T4 and your T3. The thyroid stimulating hormone is stimulated from the pituitary gland in the brain. So now that we put all that together, the thyroid gland secretes T3 and T4. Based upon the secretion of those two hormones, the TSH will thus act and secrete a stimulating hormone. I hope this isn't too much. So anywho, when your T3 and T4 are stimulating, specifically T4, because we have 80% more T4 stimulating around in T3. So when your T4 is stimulated, what we do is, based upon whether it's enough, too little, too much, will matter whether or not the stimulating hormone responds to it. So if you have too little T4 stimulating, the body will send, the brain will get a signal saying, hey, I don't have enough of T4, and thus the brain will secrete more TSH. So when you see patients with elevated TSH levels, then those patients have underactive thyroid glands. That means that the brain is getting the signal that the thyroid hormone is underactive. So when you see too much TSH, it's because it's trying to catch up for the fact that it realizes that the thyroid itself is not secreting enough T4. Thus, if you get too much T4, then the same impulse will go to the brain, and thus it will secrete less TSH. So when you see people with low TSHs, that means that they have an overactive thyroid. The body cuts that signal off. It's called a negative feedback system. So it will allow the body to secrete T4 and T3, but for this purposes, we'll talk about T4 because it's the predominant hormone. And based upon how much our body is stimulating, the TSH will be the gatekeeper, is what I'll call it. So remember, they're inversely related. So when you see a high TSH, those patients have underactive thyroids. It's responding to the T4. And thus, when you have low TSHs, then it's because the patient is hyperthyroidic or have overactive thyroid glands and is secreting too much T4. So if you have a patient that has a high TSH or a low, and have a normal T4, then we do nothing with these patients but monitor them. Remember that the thyroid is still secreting hormones, and hormones are very dependent on what's going on with our bodies. So depending on what's going on, if we are acutely ill, we may get an erroneous number. But you do want to keep up and follow with those levels and watch the levels of how low or how high it is. And I'm speaking of the true T4. So remember, if your patient has a high or low TSH, but normal T4, we call those patients subclinical, and whether it's hyper or hypo. But say your patient has a high TSH and a low T4, because they will be inversely related, then you can diagnose those patients with hypothyroidism, and then you can treat those patients with levothyroxine or any other form of thyroid supplement, T4 supplement basically. So what you want to do is start these patients on a dose. If it's an elderly patient, then you don't want to start them really high. You can start them at 50 micrograms depending on what it's doing, and then you can follow the TSH. Once a patient has been diagnosed with hypo or hyperthyroidism, then those patients will have to be followed closely, and especially in hypothyroidism, because if somebody has an overactive thyroid gland, you're not going to give them more thyroid. So let's just say that you have a patient with an underactive thyroid gland, and remember the symptoms for both of these will be directly what it said. So if a patient has a hypoactive thyroid gland, then everything will be slowed down. It's hypoactive. They will not move around a lot. They will gain weight. They will have a intolerance to cold because they're sitting all day. So remember, everything is low. If a patient has a hyperactive thyroid gland, they will be hyperactive. They will be thin because they're moving around a lot. The hair will be brittle. They'll be losing hair. These are all signs of hyper. So remember, the signs will be easy because it correlates with the disease. Hypoactive, everything is slowed down. Hyperactive, everything is up. Now remember that if you have a patient with a hyperactive thyroid gland, you can't give them thyroid replacement. These people are in immediate danger because the thyroid gland could affect any body organ. So you have to worry about these patients being tachycardic. Remember, I said that everything is hyper. So you have to worry about these people heart rate beating fast, the heart wearing out, they're getting heart failure, no period. So there's a lot of things that comes on with a hyperactive gland. Not that hypoactive isn't serious. So let's get back to the topic at hand. When you diagnose a patient with hypothyroidism, then you want to follow only the TSH. At that point, the T4 is less important because you've already made the diagnosis. So if you follow the TSH, then it should, remember, the TSHs will be elevated because it's secreting more, because it senses that the thyroid gland is underactive. So it's going to be hyper for the TSH. In those patients, you put them on medicine, you follow it every 3 months, and it should be trending down on these patients. So just follow the TSH. Now, we should always be mindful that when we put somebody on medicine, it's always possible that it can make it go the other way. Meaning that they have an underactive thyroid gland, you give them more thyroid, and now they look like they're hyperactive. So you get a patient that you put on medicine and you see the TSH is now low, that means you have them on too much medicine. Decrease your medicine dose. And it wouldn't hurt to have an endocrinologist follow these patients as well. So that's the gist of the thyroid gland. It controls a lot of necessary body functions, but it is a true hormone. So if you're ill, it may not be accurate. You may want to repeat it. If the TSH is up or down, but the T4 is normal, these patients are subclinical. They do not require treatment. Let me jump to the adrenal gland. The adrenal gland sits on top of both kidneys, left and right. It's a small gland. Its primary function is adrenaline, fight or flight, corticosteroids or glucocorticoids, steroids, blood pressure control. I mean, it's on top of the kidneys. That's a no-brainer. So what do we watch for? What I wanted to specifically talk about is adrenal insufficiency or Addison's disease and how that relates to prednisone or steroid. Steroids are given pretty freely now in the world. We get them for multiple reasons. Most people like them. If you're feeling ill, it would decrease the inflammatory system, so we love them. But if you're on steroids for longer than 5 days, the body senses that you have a synthetic form of steroid that you are being administered, and so it slows down your natural production of glucocorticoids and cortisol. So you get into a very dangerous situation when you give a patient steroids longer than 5 days and you don't wean them off, because the body has not had a chance. If you put a patient on steroids for 7 days on moderate dose steroids and then you pull them off, then the adrenal gland has not caught up and it's not releasing its normal cortisol levels because it senses you're giving a synthetic level, and you just stop that, the patient crashes all at once. Blood pressure crashes. The patient starts to look like a patient that is truly dying, and they could be if they don't get help. Glucose is dropped. All that's very important. So if you want to maintain your patient, remember, anything over 5 days, wean the steroid. The body is beautiful. It's miraculous. It knows everything that's going on. So when you give it something, it realizes it, and it slows down the natural production of whatever we are trying to do. So remember, adrenal insufficiency, adrenaline, glucocorticoids, cortisol. If you have the patient on a steroid, it's a synthetic form. The body senses it. It slows down your adrenal production of the cortisol. And then if you just stop it, the body hasn't had time to catch up, and the patient gets very symptomatic and sick. They really need to be in the hospital at this point. Hope that helped. Thank y'all for joining on. Does anybody have any questions? Thank you, Bree. All right. Well, thank y'all for joining, my love. Please share the information. Share. I really want to get out there. I want to help the most of the people that I can help. And I hope this helps you from both a nursing, a layperson, and a provider standpoint. Have a good night.